Okay, welcome to today's review of respiratory conditions. To start, we're going to talk about acute respiratory failure. With acute respiratory failure, your body is struggling either to properly ventilate or move oxygen throughout your body, or it's struggling to bring enough oxygen or enough quantity of oxygen into your body. The patient with respiratory failure may have dyspnea, orthopnea, which is shortness of breath when laying down. They might be irritable, have acidosis, and high levels of CO2 in their body. With these patients, we want to make sure that we're giving them oxygen. We can use nebulizers or meter dose inhalers, corticosteroids, morphine, and then as always, we can just increase their head of bed to help with that oxygenation. The more severe version of this is acute respiratory distress syndrome, or ARDS. In ARDS, our patient is hypoxemic despite giving them 100% oxygen. We're going to see decreased pulmonary compliance and pulmonary edema. A patient with ARDS might have a high respiratory rate, pallor or paleness of the skin, cyanosis, and you might see that intercostal retraction. So that just shows us that they're really, really working hard to get air into their body. These patients will have a PF ratio of under 200, and we're going to make sure that every hour we are monitoring their vital signs. We're doing PEEP, proning the patient, doing ECMO, and then we might also be using propofol or fentanyl. A pulmonary embolism is a blood clot that travels to the lungs. When this happens, the patient might have dyspnea, a really sharp pleuritic chest pain. So this is super sudden and super sharp. We might hear a pleural rub, crackles, they might have tachycardia, hemoptysis, and they can have those distended neck veins or that JVD on the side of their neck. Patients with a PE should have an elevated troponin and D-dimer. We're going to make sure that we are giving them oxygen, increasing their head of bed. We're going to initiate continuous cardiac monitoring and then also give these patients fluids. PEs may be treated with heparin, warfarin, or vasopressors. Another disorder that patients could have is a pulmonary contusion, which is just a bruise on the lungs. At first, a pulmonary contusion patient may be asymptomatic, but then we're going to start to see signs of respiratory failure, such as decreased breath sounds, crackles, wheezes, and then also pneumonia. You have three different types of pneumothoraxes. So first we have an open pneumothorax, and that is when the pressure inside the pleural cavity is equal to the pressure outside. In a closed pneumothorax, the pleural cavity pressure is less than outside pressure. And then in a tension pneumothorax, the pleural cavity is going to have more pressure than the outside. Signs and symptoms of a pneumothorax include sudden pain, decreased breath sounds. In a tension pneumothorax, you might see that deviated trachea, cyanosis, distended neck veins, high heart rate, and low blood pressure. To treat a pneumothorax, we're going to do a needle decompression to remove any of that air fluid that might be in the pleural cavity. We might also use a chest tube, and because chest tubes are super, super painful, we might give our patient PCA or patient-controlled analgesia. In flail chest, the patient's going to have a free-floating rib segment, and it'll move in a paradoxical manner during inspiration and expiration. Our patient might have dyspnea, shortness of breath, high heart rates, low blood pressure, low perfusion, and low cardiac output. Patients with flail chest typically are going to need mechanical ventilation. When a patient has fractured ribs, they are going to be in a lot of pain. Because they're in so much pain, our patients might not properly breathe. They might do a bunch of shallow respirations instead of fully inhaling and exhaling. This is actually dangerous because it can lead to retained secretions and atelectasis and pneumonia. So because of this, we want to make sure that we're treating our patient's pain so that they'll breathe fully. And we also want to encourage incentive spirometry, again, just to help prevent that atelectasis. Endotracheal tubes. So before a patient is given an ET tube, we're going to make sure that we're delivering 100% oxygen and also giving them fluids if they're hypotensive. We want to make sure that we're suctioning the patient and then also positioning the patient per anesthesia guidelines. After an ET tube, we're going to verify placement with a chest x-ray, and we're also going to listen to breath sounds. We want to monitor for DOPE, which is a displaced tube, obstructed tube, and then equipment problems. We're going to look at the patient's RAS score, with 0 being calm, positive being agitated, and negative being like very somnolent. We're going to make sure that we're doing oral cares every 2 hours. We're sectioning the patient, and then we're also using CHG. When removing an ET tube, we're going to rapidly deflate the cuff and then monitor the patient every 5 minutes. And we really want to make sure that the tube is being removed when the patient exhales. Complications of ET tubes include barotrauma, such as a pneumothorax or subcutaneous emphysema, stress ulcers, fluid retention, and then low blood pressure or hypotension. That is all on our complex care respiratory lecture. Stay tuned for the next video.